Hello again, everybody. We are still in the coronary pathology lecture. When we first started talking about diseases of the heart, we began with heart failure. And we really used that to kind of do a little review on just normal cardiac physiology, how we control cardiac output with heart rate and stroke volume, because of the influence that heart failure really has on cardiac output, because all heart failure is a reduction in cardiac output. So we kind of went through all the ways that you can have heart failure and then the complications as our body tries to compensate for that reduced cardiac output. We did a very brief overview on cardiac arrhythmias, a very simplified short little snippet. There is more coming in your future. And then we dove into vascular diseases of the heart. And this is where we're picking up today. So we already introduced that when we're talking about coronary vascular disease, we're really talking about the exact same pathophysiology as atherosclerosis. The formation of plaque in the blood vessels happens to occur in the coronary vessels. And when it does, it limits the ability to deliver blood to the myocytes. And this is particularly problematic in the heart because myocytes are what we call flow limited. At rest, they're taking all of the oxygen out of the blood. Another way of saying that is that there's maximal oxygen extraction at rest. So when your heart rate increases and your myocytes need more oxygen, the only way to deliver that oxygen is to increase blood flow. You need to be able to vasodilate and increase the total flow through your vessels. If they are filled with atherosclerotic plaque, the diameter of the vessel will be reduced, limiting the ability to deliver that blood flow. But the walls are also going to be much stiffer. If you think about that plaque and the growth of the vascular smooth muscle cells laid down with extracellular matrix, the walls become incredibly stiff, which means they're not going to open and close upon demand. So we introduced that someone might have disruption in blood flow without causing any cell death, and that would be stable angina, right? With a known stimulus, they can get some chest pain. Stable angina is not in and of itself life-threatening. It's not even really necessarily damaging to the heart, but it is a warning, right? That tells you that you have atherosclerosis. So if you're reviewing your notes, really think about the medications that they're giving a patient who has stable angina. This is not a good situation, and they're doing things pharmacologically to try to prevent the patient from progressing onto acute coronary syndrome. And again, acute coronary syndrome is the big umbrella term for an acute obstruction in blood flow. And that's kind of where we left off. We were talking about the different types of acute coronary syndrome, from unstable angina, where there's chest pain not relieved with rest, but the ischemia is not so severe that it causes cell death, to a true myocardial infarction, which is what we can see on the screen here, an image of an infarcted heart. And again, the myocardial infarction can be a subendocardial myocardial infarction, as we see here, where it's not a full blockage of the coronary artery. There's severe obstruction that causes cell death, but the area closest to the blood supply has a chance of living, as opposed to a transmural full thickness MI, where that entire blood supply is clotted and you get cell death across the entire wall of the ventricle. So let's now talk about what this looks like for patients, the signs and symptoms of a myocardial infarction. This is an important list to know because this is something you will always be monitoring for. So of the things that maybe reach the peak of most important, knowing cardiovascular risk factors, because every single time you do your subjective history, every single time you do a chart review, you should be sort of keeping a running tally of their cardiovascular risk. And then when there is cardiovascular risk, you want to be hyper alert for signs of cardiac ischemia. So being familiar with what those are is incredibly important. So chest pain is probably the most well-known symptom of myocardial infarction. The chest pain notably is unrelieved with rest. So many patients who end up in a myocardial infarction have chest pain to a known stimulus that goes away with rest, but we call that stable angina. When it's not relieved by rest, not relieved by drugs, many patients who have stable angina are treated with what's called a sublingual nitroglycerin. You just put it beneath your tongue and it just dissolves and gives you a very quick dose of nitroglycerin. So that will be a common approach that a patient would have to reduce their chest pain. And if they take their nitroglycerin and it does not relieve their chest pain, that is a kind of negative finding. That is a bad sign for a myocardial infarction. Radiating pain down the left arm into the jaw or the neck can be a very common sign of myocardial infarction. This is actually more common in women than having chest pain. So even though in like every single movie you've ever seen where someone has a heart attack, they grab their chest and fall down, many women do not have chest pain as a symptom, but rather have the kind of radiating pain is more common in women. Dyspnea is, again, that sensation of difficulty breathing. So a sudden experience of dyspnea and shortness of breath can be a sign that they're experiencing myocardial ischemia. Nausea and vomiting can be a sign. Sometimes individuals who are having a myocardial infarction actually confuse their symptoms with GI upset. So they'll describe it more as heartburn or kind of having something wrong with their GI system, but it's truly actually signs of a myocardial infarction. Profuse sweating and then a rapid, weak pulse is common. And it's helpful to kind of think this through, and so you don't just have to memorize this list. Both kind of sweating and rapid pulse are signs that they're having a big sympathetic stimulation. The body is aware that things are going poorly. And most often during the myocardial infarction, the heart isn't functioning very well, right? Because even the cells that haven't died, if they are cells in hypoxic injury, they're not squeezing hard. So it's very common that during the myocardial infarction, there will be a reduced cardiac output. And reduced cardiac output is going to activate the sympathetic nervous system. So if you think of a big sympathetic nervous system activation, you would expect a rapid pulse. You'd expect some sweating. Now, the weak part is important. We feel a pulse by putting our hand on a peripheral artery, and you feel the bolus of blood going under your finger. If the heart is undergoing a myocardial infarction and there is reduced cardiac output, you would not expect a nice big bolus of blood. So it will feel like a very weak, rapid pulse because there actually isn't big waves of blood going because the heart isn't functioning very well. I always find that if you kind of talk through the reason that things are on a symptom list, it's much easier than writing a list and memorizing it. I think it's easier to learn, and it will also stay with you a lot longer. Something to think about. Oh, I gotta get all my markings off of here so you can see my final one. The last one in your list, and is in the green box on the slide, is there is a chance that someone can have a silent MI. So someone can have a myocardial infarction with no symptoms. I want to put that on your radar. That's not really something that you can necessarily screen for because there's no symptoms, but I want you to be aware that patients will sometimes go in to their doctor for some other reason, and they might find evidence of a previous myocardial infarction, and patients will have had no knowledge that it happened. This becomes more common in our diabetic patients. So we'll return to this concept when we talk about the phenomenon known as autonomic neuropathy. Autonomic neuropathy is neuropathy of the autonomic nervous system. So when patients have diabetes, they can lose some of the kind of feedback from the system to get these symptoms in the first place. And so they are more likely to have a silent MI. So these would be signs and symptoms that you might observe or the patient might describe to you. If a patient shows up to the ER with chest pain or signs of myocardial ischemia, they are going to very quickly put EKG patches on the patient to start to get their EKG, and they will draw blood to look for circulating evidence of a myocardial infarction. So in your notes under laboratory findings, let's first talk about the EKG. And there's a lot to look for here. I'm going to give you the big one, the big changes that go with MI, and we'll get into some of the nitty-gritty details of how things change when we get into our deeper talk of EKGs in your final PT year. So one of the biggest EKG findings with a myocardial infarction is changes to the ST segment. So we label the curves of the EKG with the letters P, Q, R, S, T. And the area between the S and the T is called the ST segment. When the heart is functioning normally, the ST segment should be flat. And what I mean by that, if you look at kind of where the P wave starts, I'm just going to kind of dot this line here. My green dotted line is what's referred to as the isoelectric line. That's kind of like neutral, no signal one way or the other, no positive or negative. And the ST segment should be on the isoelectric line. When the ST segment is elevated, and I'll draw your attention kind of right here on the EKG. Actually, let me take this isoelectric line all the way across so you can clearly see that the ST segment, right from here, kind of there, has been elevated. It's up off of the isoelectric line. This is called ST segment elevation. When someone experiences a transmural MI, it will be evidenced on the EKG by ST segment elevation. So this EKG showing ST segment elevation would be expected in a transmural MI. For that reason, this type of heart attack is often given a different name. It is often called a STEMI. And this is actually an abbreviation. The ST stands for ST segment. So this is ST segment, is the ST of STEMI. E stands for elevation. And then MI is myocardial infarction. So if you've heard the term STEMI, that is actually an abbreviation for ST segment elevated myocardial infarction. So ST segment and transmural MI are two names for the same thing. And you will see it written, both ways in different times. ST segment elevation. In full thickness, non-transmural MI, you can get what's called ST segment depression. And you can see ST segment depression where the ST segment goes below the isoelectric line. So the EKG would be kind of down here. That can be ST segment depression can be seen in both subendocardial MI as well as unstable angina. You can see that in both. ST segment depression. That's a sign of cardiac ischemia. So a transmural MI is sometimes called a STEMI because of the evidence that shows up on the EKG of ST segment elevation. Because we have two types of MI, the subendocardial and the transmural, since the transmural is often called a STEMI, then the subendocardial MI is frequently referred to as a non-STEMI. Non-STEMI tells you that you had an MI, you had a myocardial infarction, but there was no ST segment elevation. So a non-STEMI MI is synonymous with the subendocardial MI. Two names that mean the same thing. So I mentioned they're going to draw blood, and this, to understand what they're looking for in the blood, it's really helpful to think back to Unit 1 when we talked about hypoxic injury leading to cell death. So in cellular necrosis, the cell swells. The phospholipid membrane gets degraded by phospholipase and reactive oxygen species. And the cytoskeleton is degraded, and eventually you break through the membrane and intracellular elements spill out of the cell and are in the interstitium and eventually picked up into the blood. So when you have a myocardial infarction and there's true cell death that happens, there are myocytes that spill their intracellular elements into the blood. This is a really important distinction because a patient who had unstable angina, severe sudden chest pain that's not relieved by rest, but it's not so severe where it causes cell death, nothing should be spilling out of those cells because they have not died. And anything that normally lives inside of a myocyte should stay inside of a myocyte. When you have a myocardial infarction, there's true cell death. So intracellular elements spill out. So when someone comes in with evidence of a heart attack, subjective signs of a heart attack, they're going to look in their blood and see if there's anything circulating in the blood that shouldn't be there and rather should be inside of a myocyte. So let's go through each of these. Okay, so the first is CPK, and CPK stands for creatine phosphokinase. Here, oops, erased it somehow. I'll write it on the screen for you. It's creatine phosphokinase is CPK. This is an intracellular enzyme, CPK, an intracellular enzyme, which means it lives inside of a cell, and it has its greatest amount in the skeletal muscle, the heart, and the brain. So there really shouldn't be much of this floating in the blood. If we see high amounts circulating in the blood, this can be evidence for a cell death of a myocyte. You can get more specific by looking at CK-MB, the percent of it that's from the muscle and brain. So this is CPK in muscle and brain, and that can give you an indication of kind of the origin that we're looking at. So if you look on the figure on the right, you can see CPK is found here, where you can see that the concentration rises in the blood after the event, and CPK pretty quickly gets cleared out of the blood again. The next one on the list is troponin, and troponin is considered the gold standard for identifying a myocardial infarction. And that is because there are specific isoforms of troponin T and I, that are only found in the heart. So if troponin is elevated in the blood, they're really the only source of the isoforms that you're testing for that could be there must be coming from the heart. So troponin is considered the gold standard. The negative with troponin is it takes a little longer for it to show up in the blood. It's typically about 6 hours after someone starts having symptoms where you have evidence of troponin in the blood. So if you show up at the ER really quickly, that might not be circulating in the blood enough yet to be able to identify the myocardial infarction. As you look at the table in your notes there, you can see there's, first a minor cardiac event, and then it talks about a major cardiac event. And the number or the concentration of the circulating enzyme goes up with a more severe cardiac event. Hopefully this is intuitive because these enzymes are supposed to live inside of a myocyte. When a myocyte dies, it releases its intracellular enzymes, and now they're found in the blood. So if only a few myocytes die, there would be very low amounts of the enzyme in the blood. If you have a massive cardiac event and thousands and thousands of myocytes are dying, the amount of enzyme that's released in the blood is going to be much more. So that is why you see higher concentrations of enzymes indicative of higher or more significant cardiac events. The very last one on the list is myoglobin. And myoglobin is a really handy circulating marker because it's highly sensitive. And what I mean by that is if you have a myocardial infarction, myoglobin will be in your blood. So very high sensitivity, extremely low specificity because it could be coming from any of your muscle tissue. So if you have a skeletal muscle injury, myoglobin goes up. So it is very good it's used primarily to rule out an MI, right? If you have signs and symptoms of a myocardial infarction and no myoglobin in your blood, it is very unlikely you're having a myocardial infarction, because if you are having an MI, myoglobin should be in your blood. So that can be helpful to rule out an MI. So you showed up to the ER with the subjective signs and symptoms of a cardiac event. They will quickly look for evidence on your EKG that might indicate either ischemia or full infarct. And they're going to be drawing blood to look for circulating enzymes. So on the top of the next part of your notes, I have kind of a big blank space. I like to put all of this together in a summary figure so we can kind of look at them side by side, the three different types of things that can happen to the heart during acute coronary syndrome. So I'm going to go to the whiteboard and draw this out for you. So let's draw a summary of all of our acute coronary syndrome. So I'm going to put that at the top, ACS, acute coronary syndrome. And we're really talking about a collection of conditions or an umbrella term for blood supply that's suddenly stopped, right? So this is a sudden decrease in blood flow. Kind of all of these share that in common, but then the significance or how severe that blockage of blood flow really separates our acute coronary syndrome into three separate categories. So first we have unstable angina. Second, we have the subendocardial MI. And lastly, we have the transmural MI. On the bottom of this, I'm just going to draw the picture that goes with it. And by that, I mean I'm going to draw that piece of the ventricle wall with the blood vessel next to it. So down here, this guy, maybe I could even, to make it clear, we could even color it in red to show that this is the muscle, this is the ventricle wall. And on the outside is the blood vessel. In a unstable angina, you get partial occlusion. So I'm going to just kind of color this in by half and maybe even write partial occlusion. And then really significantly, if we look at this muscle, there is no cell death. Let's draw that same figure for the others. So here we again have the wall. This is kind of losing the, there we go. Here's the blood vessel. Ah, no, that's a highlighter. Screaming at my drawings. I probably works a little better in real life and lecture than listening to a video, but such is life. Okay, subendocardial MI. We're going to have a more severe occlusion. So I'm going to try to color my circle in a little bit more than I did in the last one. So here we again have partial occlusion, but more severe, right? We've caused a greater amount of blockage than you see in unstable angina. And this is now going to lead to cell death of the subendocardial region. But the area of the muscle that's the closest to the blood supply, oh, I think occlusion might be popped off your screen on there. I just noticed that. Maybe I can add it here, partial occlusion. The area that's closest to the blood supply will live, and the myocytes that are farthest away from the vessel will experience cell death. And then the last one is the transmural MI. We'll draw the blood. Ugh, I did it again. It's funny. Draw the coronary artery here, and we will have a complete occlusion. Maybe we'll draw it up so it doesn't fall off your screen. Complete occlusion. And because it's completely blocked, you will have cell death across the entire wall of the ventricle. So you get full thickness cell death. So you should be able to see that the severity increases with greater and greater occlusion. So for each of these, there are the subjective signs and symptoms are largely the same, right? So patients might have chest discomfort, they might be sweating, pale, cool skin, rapid, weak pulse, GI upset. Those symptoms can all be the same across the spectrum, and you can't tell from the symptoms where you are on this chart. So if we kind of look at the ACS itself, they all have sudden decrease in blood flow, and they can share the same subjective evidence of the MI. But when they come in, they're going to be immediately given an EKG. And in unstable angina, you might see evidence of ischemia, but you would not see kind of evidence of a full thickness cell death. So under unstable angina, you might see ST depression, which is evidence of ischemia but not cell death, full thickness cell death. Similarly, in a subendocardial MI, you can get ST depression as well, evidence of ischemia. But in a transmural MI, you would expect ST segment elevation. Because of that, right, these can be called another name. This can be called a STEMI, which stands for ST segment elevation myocardial infarction. And this guy can be called a non-STEMI. You would never call unstable angina a non-STEMI because the MI in STEMI stands for myocardial infarction. Lastly, right, they're going to draw blood and they're looking for cardiac biomarkers. In unstable angina, there is no cell death. If there's no cell death, there is no mechanism whereby myocardial enzymes would end up in the blood. So you would expect no biomarkers. By biomarkers, that's cardiac enzymes in the blood. In a subendocardial MI, there is cell death. The cells that are in the subendocardial region are spilling their intracellular elements into the blood. So when they test the blood, you would expect biomarkers present. And then with a transmural MI or full thickness, obviously there is cell death. So intracellular elements would be spilling in. And this would be probably the most, right, in the blood. It's different from person to person, but this would be evidence of a massive cardiac event. Biomarkers present. So you can see that where they all share a common mechanism and maybe even common signs and symptoms, the medical team can parse out whether they're dealing with unstable angina versus an MI by looking at the biomarkers, and then can determine the degree of infarct by the evidence that's seen in the EKG. Let's go back into the PowerPoint now and talk about what happens to patients when they're experiencing an MI and complications that can come once the heart has gone through this type of an injury. So your notes on page 59 says complications of MI or myocardial infarction. One of the things that can happen is that a patient can go into heart failure. And as you guys hopefully know, that heart failure means there's a decreased ability to maintain cardiac output. So if the ventricle has a huge chunk of it that's experiencing cell death or hypoxic injury, it is not going to be able to generate a good, strong contraction to maintain the stroke volume. So because of the injury to the ventricular wall, you can lose the ability to maintain cardiac output. So what does that look like for a patient? If they're going into heart failure and not maintaining cardiac output, you'd expect very low blood pressures, right? Hypotension. You might start to see evidence of congestion, like pulmonary congestion, where fluid is accumulated in the lungs. They might get peripheral congestion, right? Peripheral edema, jugular vein distension. These can all be kind of outside evidence of heart failure. The next thing that can happen is what's referred to as cardiogenic shock. And actually near the end of this semester, we'll talk specifically about what shock is. But for your purposes now, a patient goes into shock when there is insufficient blood flow and oxygen to tissues to meet their metabolic demands kind of globally all over your body, right? So at every moment, you need to be perfusing your liver and your kidneys and your lungs and your GI system. You're delivering oxygen to all of these areas. If someone is failing to deliver their cardiac output, there's going to be such a little amount of blood going around the circulation that they can go into shock. And this can lead to death if someone goes into cardiogenic shock and it's not corrected. The next really, really common complication of MI, in fact, 90% of patients who have a myocardial infarction develop some type of a rhythm disturbance, is that they develop an arrhythmia. You see even more of this when someone has a STEMI versus a non-STEMI, but this is something that everybody is monitoring for once you've had a myocardial infarction. The next one on the list is valvular insufficiency. And this can occur because of infarct to the papillary muscles. So if you remember, valves are actually under some control of the muscle, right? That is actually can contract and help maintain the integrity of the valve. So during systole, your papillary muscles contract to prevent the tricuspid and the mitral valve from inverted, like having an inversion or a prolapse. So if the muscle, it's infarcted, and this is the muscle that's damaged, well, you'll no longer be able to do that. So after an MI, some patients end up having regurgitation of their valve or like blood that leaks backward. So a really common occurrence is to have mitral regurgitation. Blood leaks kind of back into the left atria during systole. So it's going to make the pumping less effective because, when your ventricle is squeezing not all the blood is moving forward, right? As it squeezes, some moves backward and some moves forward. That's an inefficient pump. A huge fear and negative is the possibility of experiencing a myocardial rupture. And you can see that evidenced here from this individual who died from it. About 1 to 5% of myocardial infarctions will experience a rupture. It's almost always fatal when it occurs. The timing of this kind of matches the point of greatest weakness. The dead muscle, when you have the infarction, it causes cell death. The dead muscle has to be removed, and it has to be replaced with collagen and scar tissue. At around 5 to 7 days after the myocardial infarction, it's going to be at the weakest point because the scar isn't yet mature. So the scar is going to be weak, but the cells are being taken away. And that's the point of the greatest risk of myocardial rupture. The other picture here on the slide is cardiac tamponade. Cardiac tamponade is when you have fluid that accumulates in the myocardial sac. So our heart actually sits right in the myocardial sac, and if there's bleeding into the sac or inflammation that has fluid accumulating in the sac around the heart, it compresses the heart from the outside and makes it unable to fill. This is a serious life-threatening emergency because the patient will very quickly go into severe diastolic dysfunction because there's something squeezing on the outside of the heart which will limit your ability to fill. The last one on the list is a mural thrombus. So that's a blood clot. Mural just means it forms in the wall. The risk of thrombus goes up during a myocardial infarction because at the time of the MI, there is reduced contractility. So when the heart isn't squeezing well, there is blood stasis within the ventricle. On top of that, when you have endocardial damage, right, that can lead to more of a thrombogenic surface. It's more vulnerable to clots. The big risk here is if you form a blood clot in your heart and then your heart is contracting, the blood clot can become an embolus and you're on the arterial side, right? You're going to pump this out into an artery. This could go up to the brain and cause a stroke. So after a myocardial infarction, there is an increased risk of stroke because of the increased risk of forming a blood clot within the blood that was in the heart during the MI. So for treatment purposes, the goal of the pharmacological agents that they put on board is to reperfuse the heart as soon as possible. So they're typically treated with a vasodilator agent. It's usually nitroglycerin. They'll be treated with something to actively dissolve the clot, so thrombolytic agents. So tissue plasminogen activator is actually the same name of the endogenous tissue plasminogen activator, the one that our endothelial cells make that break down clots. We can deliver it like a drug to help actively dissolve the clot and get the blood flow restored. And then they're going to be given antiplatelet drugs to prevent further blood clotting. And in an inpatient setting, this is almost always a heparin drip that it can be, in addition to the antiplatelets, patients are often also given a heparin drip as an anticoagulant. Many patients will require or benefit from surgical options to more quickly open up the blood vessel and restore blood flow, or immediately after the event, once they've determined how unstable their plaque is, they might have a surgery to prevent another MI from happening. So probably the two most common surgeries that you'll see. The first is an angioplasty, and it can include a coronary stent. It doesn't always. But an angioplasty is what you're seeing here is they take a catheter and they thread it into the coronary vessel. So they start in the periphery and they thread a catheter up through the peripheral vascular system into the heart. And they, it would come, they'd thread it down into the coronary vessel. I guess red on red isn't very helpful. And the end of that catheter has, I got to change my color. Let's try this again so you can actually see it. The end of that catheter has a balloon on it. It's deflated so that it can fit through the small peripheral vessels, but once they get to the spot that has the plaque, you can kind of see the yellowy moving in, they inflate the balloon. So here you can see the balloon inflated, and they really are just taking the balloon and smashing the atherosclerotic plaque into the walls. They're kind of trying to smush it. So they balloon it out, try to smush it into the walls. Then they deflate the balloon and they pull it out. That's an angioplasty. What they have found is that a lot of times when they deflate the balloon and pull it out, the plaque just goes back to where it was. So most of the time when this procedure is done, it's an angioplasty with stent. And the stent is this wire mesh that you see here. So on the first slide, you can see the stent is around the blood vessel and it's like a collapsed wire mesh. When the balloon inflates, the wire mesh is opened up. Then when the balloon deflates, the mesh stays and the balloon comes out, and then the wire mesh is meant to kind of hold that vessel open for, so that the plaque doesn't kind of rebound back into the lumen. And this is a highly effective treatment. It works very well. It's very low in terms of invasiveness because you don't have to have a big open heart surgery. They can thread this in through the peripheral vascular system. So that is a really huge plus for patients' recovery and patient outcomes. If it's a more severe plaque that wouldn't respond to an angioplasty, or if there's multiple locations, they might opt for a coronary bypass surgery. And if I can orient you to the picture, you can see this individual has two areas of severe blockage or narrowing, kind of identified with the circles around it. In coronary bypass surgery, they take another vessel. So let's look at the blue one first. And they anastomose it to the aorta. So they stitch it into the aorta. So now blood is going from the aorta into this new vessel. And then they stitch it onto the coronary vessel just distal to where the blockage is. So the block just right north of here would have prevented blood flow to all that downstream vessel. So you're stitching in a new vessel just downstream of the obstruction. So now all the rest of those downstream arteries and arterioles have a straight supply from the aorta. Another version of this is to take a vessel that normally branches. A typical artery used is a mammary artery, and so then it only requires one stitch, and they don't have to take the vessel from somewhere else. They just take a normally branching vessel that occurs in your anatomy, and they redirect it to an area distal. So there's multiple versions of this. If somebody uses a vein from another part of their body, a very common one used is the saphenous vein, then those patients would have a leg incision. But those that can use a thoracic artery that's already in place, they don't need the graft. They can just use a vessel that's in place. You will see both. You'll see multiple in one patient. It'll kind of vary based on what the surgeon's options were at the time. So this is a highly effective surgery. It's just a much more involved surgery because it would involve open heart surgery. So again, we're going to talk a lot about what we do with patients like this and the full gamut of their responses. But for now, just to kind of put it on your radar, PT usually begins 24 hours after an MI. So good cardiologists, most cardiologists, are really big on, as soon as they are hemodynamically stable, to get them up, because the heart will heal better when it has some stimulation and stress put on it during the healing process. So we're called to the scene very, very early on. Goals here are to prevent venous stasis. You think of why this is important, why everyone's worried about venous stasis. You do not want this patient to get a blood clot, so you need to get their blood moving. We will talk about the whole host of cardiopulmonary complications, but after an MI, right, you're very prone to arrhythmias, as we already mentioned. We're very prone to lung effects because of the change in the blood flow and the stress that the heart and lungs went under. And then what we already, our wheelhouse, just joint stiffness and muscle weakness. If they stay in bed, they will do worse. So we typically are involved in very early mobility. We do a lot of breathing techniques to stretch out the rib cage and get them breathing, get them coughing to prevent pneumonia. Really, really important role in getting patients out of the hospital with better outcomes. Some things to know if you see any of these patients on your first rotation is they are most often on some type of analgesic. So that's going to block the pain from giving them any kind of feedback as to how hard they're working in exercise. So you have to be hyper vigilant on monitoring their vital signs and being really careful not to overexert them. We want to avoid any breath holding or Valsalva because it can cause an unsafe rise in blood pressure. So just kind of some things to think about. We're really thinking about what we are doing as therapists that may be causing stress on the heart and things that might raise blood pressure because the heart is healing during this time. We're both very important part of the healing process, and we also have to proceed with complete caution so that we don't overstress the heart. And of course, lots and lots more coming. So here's just a little mini plug. If you are someone who is approaching physical therapy because you have a deep love and excitement of exercise physiology, I strongly encourage you to just keep the door cracked open in your mind for having a cardiopulmonary specialty. There's no other branch of physical therapy that uses the principles of exercise physiology to help patients more than in the cardiopulmonary world. The strength training and the goals of strength and conditioning are well applied to many, many fields. But cardiopulmonary specialists, we use the kind of aerobic mechanisms of exercise to treat patients. And it's incredibly exciting. We're on the front line. We're this vital part of the medical team and decision making and getting patients onto transplant lists and getting patients off of heavy duty equipment to support their life. And so I've been teaching cardiopulm enough times that people are like, I didn't know this was so exercise physiology. This is so cool. So if you're someone who loves exercise as medicine, just kind of keep it open because it's incredibly exciting to be the person that knows exactly how exercise can help someone whose heart is so weak, and you can make a huge impact on their life. So it's super exciting. As you can tell, I care deeply about this, so I'm just trying to spread the love. Spreading the love. I hope you guys enjoyed the lecture. We get to pick it up. The second half of this Friday lecture series will be on the blood vessels. So I'll see you then. Bye.